Hey everybody, this is Dr. Ben Pearl with FitFoot U, and today I have Mireille Blanchette, Dr. Mireille Blanchette. She is a podiatrist hailing from Canada. I'm going to let her tell everyone about her training, but now she's practicing in New Jersey. First, welcome. It's good to have somebody from originally from up north. I'm
Hmm.
originally from up north in Albany, but you're a bit north of me.
Oh, I didn't know you were from there, but yes, I'm a little bit more north for
Yeah.
sure.
So with before we get into your training and so forth, what got you interested in podiatry?
So it was I don't know, kind of a luck of the draw. So I knew I wanted to, like go to university and everything, and then I was working at a pharmacy. I was on my feet a lot, and then my feet were hurting. And then in my hometown, we didn't have podiatrists. And then I would see all those, people like little old people like coming and then buying the like, cushion for hammer toes and things like that. And I was like, oh, there's a need for it here. And then I wasn't too sure what to do because we didn't have a lot of money. And then I was telling my parents, I'm like, I think I'm just gonna work for a year and then I'm just gonna see next year what's gonna happen. And then one of my friends told me, she's like, I sent all my application for university, and I was like, well, like it made me realize I'm gonna lose a year. So that day, instead of doing my homework, I just took, all the pamphlet that I had from all the university or the college or whatever, um, in the that I had accumulated over the past few months, and then I just looked at everything, and then the only thing that stood out was podiatry. So it was a new program over there, and it's in the University of Quebec in Trois-Rivières. It's in Trois-Rivières between Montreal and Quebec City. And then it was a new program. You had an externship in New York City. And then I had pain in my feet, and then we didn't have a podiatrist. And I was like, oh, maybe that's going to be interesting. So this is how I got into it. And then, like you can also like do surgery and everything. And it was just kind of a well-rounded up profession, I thought.
Mm-hmm. And so then what brought you back down to the United States?
So over there, so basically, I was in the second year of the program there. So I did podiatry school in Canada from 2005 to 2009, and then I worked there for a year. But I really wanted to do surgery, so it's because I wanted to do surgery that I came here because we don't have residency for podiatry in Canada. So basically, I came here. I had to redo the last year of the podiatry school, and I did that at NYCPM. And then after that, when I graduated, so that I had my American diploma, and then I had done, like the boards leading to residency. So then I did my residency for 3 years to become a surgeon. And then the plan was always to go back to Canada. But then in my last year of residency, I started dating who is now my husband. And then we're married, we have kids. And then I just opened my new office here in Mount Sinai in New Jersey.
And how long have you been in practice now?
7 years. No, 8 years. So it was, I was working in Princeton for 7 years. And then we had our second and third child. We just had twins last year. So we have a 5-year-old boy and then twin girls. And then after having the twins, when I went back to work, the commute is an hour from my old job. And then I just realized it was not feasible. I went back to work the first week. I told my husband, like, it's not going to work. And then I just, I worked there for another 3 months or so. And then I quit. And then I was home for about 10 months with my girls, which was good. And then as I was building this practice, and then we just opened in June.
So you have some unique ways that you communicate with your patients. Tell us about it. You do a lot of social media.
Yeah. So I try to, like it's very, I don't know, a lot of people are like to go online and then to see to be educated, right? Like sometimes on like YouTube, like you do, and then there's also Instagram and then Facebook and things like that. And then I just got into Instagram. I don't even know like why. And then they have reels, so it's just kind of like short videos similar to TikTok. And then I just like to educate patients with that. So usually there's kind of like, an audio that's like catchy, and then I'm gonna put my own twist on it. And then usually in the caption, I'm gonna, like educate about let's say like foot pain, what to do if you have this or that, things like that. So
Yeah, I saw a few, and there's always a subtext of information, even if you do it in a comical way. Like I think you
yeah.
did one with Whoopi Goldberg's voice from The View. It sounded like her anyway. And then you had some information about taking oral antifungal medications isn't necessarily a death sentence.
Exactly. And then so I do those videos, and then also I try to do like on Mondays a Mythbuster Monday, that there's like a common myth in like podiatry, and then I just kind of go in and put my own twist on it, and just to explain like why this is not necessarily true.
So what have been your top myths that you think you've put out there that you busted up?
So I've done few. So this morning, that's funny, yesterday actually, I put one of that kids will always outgrow their flat feet, which I think is a big one, because like there's a lot of concerned parents. They go to their pediatrician or to the orthopedist, and then they're like, my kid has flat feet, and they're gonna grow out of it, and then they kind of like brushed off to the side, and then sometimes they come and see us a little bit later. They're like 10 years old, sometimes like early teenager, and then they start having issues, and we're like, oh, it's because they're flat-footed. Then we put an orthotic and they feel better. But then if it had been done maybe earlier, sometimes you can maybe have the orthotic for a certain time as the foot develops, and then after that you may be able to remove them. And then I finished that that myth buster just saying, if all the flat feet would resolve, no adults would have flat feet, right? If all the kids would outgrow their flat feet, we wouldn't have any patients that have flat feet as adults. And then we have a ton, and then they have a lot of issues. Not everybody has issues probably, but of course I see the one that have issues because they come and see me to the office. But like plantar fasciitis, posterior tibial tendonitis, all those things can be related to flat foot deformity. So that's
what have been some of the interventions that you've liked to do for flat feet that have worked best for you?
So oftentimes people come in and then they have an equinus, like their calf muscle is tight. So then that's always one of the first things that I recommend is going to be to stretch their calf muscle. So they can either do a regimen at home, and then they can do physical therapy. Orthotics is a big one. And then there's sometimes a stigma again, like around orthotics. People are like, oh yeah, I don't want orthotics in my shoes. And I'm like, why? I'm like, I have orthotics in my shoes. And I show them my orthotics and, like how I've been using them, and then how they work, and how they're supposed to like, curve with your feet and everything. And then how they're supposed to work. I even like put them on the floor, I put my foot on it, and then I kind of show them, let's say my big toe works better when I'm using my orthotics. And then, so orthotics is a good one. And then to do some, like strengthening exercise also can help. But mainly the orthotics, I feel like it happens a lot that, let's say patients go to physical therapy, and then they're told, walk this way. Like you're walking too much this way, walk a little bit that way. And I'm like, but try not to force yourself to walk a certain way. Let's put something in your shoes that you're going to be walking normally, but like the device itself is going to be helping you walking better. Because if not, like if you're trying to walk, more this way, not putting as much pressure, well, the peroneal tendons, like all the other muscles around, like are going to be sore, and then it's not going to be comfortable. So I feel like it's just better. You put something in the shoe, and then you have like a good shoe, put, a device in the shoe, and then you're going to feel better.
Now you trained under one of my classmates, Dr. Dominic Cantonese.
Yeah.
What's the most interesting thing or meaningful thing? I'm sure there's more than one that you've learned that you've kind of keep with you that you got out of your training with Dominic.
So he was my mentor. Like we have always like different attending and residents that we like, and then I really loved him. I learned a lot from him. Like we were doing surgeries on Thursdays usually whenever I was like under their rotation, and then it was just nice that just the ambience like in the operating room. And then he's like like very like calm, and he can be upset when you're not doing what you're supposed to do. Like thankfully it wasn't me, but I've seen him upset with like other residents. But it was just like the ambience, and he's just like such a nice person, and then he's like very knowledgeable, of course. And then I feel like we had this mutual trust. I really always took good care of his patient, and he was telling all the residents like, you should do what she's doing because she's doing good. Like he said, he was telling everybody like I knew his patients sometimes better than him, even though I've never met the patient, because when you're a resident, you have a case, and then you're going to do that surgery. You don't necessarily go to do a surgery on Mrs. Smith. You don't necessarily know Mrs. Smith. You're going to do a bunion on Mrs. Smith. The procedure you're going to do. But then in my case, I always went and then I looked at the chart. I knew like Mrs. Smith had like this type of surgeries in the past. So like she had this allergies, her labs were this. I knew everything. I had put all this on paper. I was like printing the x-rays and then doing the lab, not the labs, but like the angles and everything. So he knew, like, the trust was mutual, that I was giving him so much, or showing him so much I was ready for his case, that, like I did a lot in his surgery. Like he was not operating. I'm the one who was doing the whole surgery. Then there's a funny story once, is that, so I got up in the morning and then left with my car, and then I got a flat tire. Then I was on my way to do surgery with Dr. Canis, and I got a flat tire. So then of course I got late. I called my now husband, and then he came and like we changed cars and stuff like that. And then when I got to the OR, I don't know, like maybe half an hour late or something. And then Dr. Canis, instead of being upset at me, he just, he gave me the knife, like I continued the surgery, because he just knew that this is not something that happens often. And then he had made a joke about it. He's like, look at her, like she owns the OR. She comes in late and then she's just like doing surgery. But it's just this relationship that we had.
Yeah, I think that's really important with the healthcare team. Your supporting staff can make or break you, and your co doctors, your team. Mm-hmm. So if they're on point and in sync, it makes a better patient experience, and it makes a better doctoring experience for sure. Exactly. Was there anything that impressed you with his approach to how he dealt with patients? Obviously, he had a good bedside manner, and with you and with teaching residents. But what about in terms of things that you learned from his approach to either surgery or care or education for his patients?
So we don't see, in residency, we're not in clinic a lot.
Okay.
We're in clinic, in our own clinic, but then let's say the main attendings, they had their own office hours. So let's say, like, I remember, like, there was one patient that we did a flat foot reconstruction on, that I was taking the time out of my schedule to always go into his post-op, because I always wanted to see that patient and see how he was doing. So then, it's not like we don't see a lot of that interaction here and there. But otherwise, in it's just his, I don't know, his calm, I think, and then like the way he interact with people, with staff also, it's just he's very
some people are people, and some people are not people. Yeah. So he's more of a people person. I will tell you this. I ran into him randomly. It was Hurricane Sandy. We were at Mohonk Mountain Resort, and I'm going up the stairs with my kids, and he's like, Ben Pearl? And we hadn't seen each other in 25 years. Wow. 20 years, something like that. And at any rate, I spoke to him a little bit. We kept in touch. He talked a little bit about nerve ablation. But one thing that I think is important with patients and patient care that I got from him, when he talks about things like, let's say it's a nerve problem, what I had done formally, and I guess sometimes you have to choose how you're going to approach certain patients, but what I had done formally is I would tell Mrs. Jones, we're going to try this arch support, and we're going to then do some stretching. And these are for, this is what we're going to do. And then if that doesn't work, we'll come back. What he did that's different, that I was impressed with, is he would say, let's say it's a neuroma. Mrs. Jones, first we're going to try, let's say, offload padding, and we're going to do this cortisone shot if that's what he chose to do. But then he would give the whole battery of things that he would do kind of from start to finish, that we might have to do a nerve release, ablation, and kind of take it to the finish line. And I found if you do that approach, and let's say a patient that I don't do a cortisone shot for a heel pain situation doesn't get relief, now if I hadn't already told them, well, we could do a cortisone shot, we could do shockwave therapy, we could do, now I do electromagnetic therapy, another therapy that I like to do. If I hadn't told them these are next measures, they think, well, that's all they've got. I'm moving on. And then you never see the patient again. So I think that was an important clinical thing that I got just by talking to them. And it's just an approach of just making sure that the patient always has the dots connected, because if they don't see the dots connected in front of them, they won't connect the dots.
Exactly. Because in our, in our head, we know this trail of, like if A doesn't work, we'll do B, blah, 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 blah. But then patients don't know that, they don't even know A. So like, how can they know, F, so they just need us to kind of like guide them. And then I do that too as well. When I tell patients, I'm like, this is what we're going to try now. If it doesn't work, there's always other things that we can do. And then, up to maybe like surgery. And then sometimes people are like, oh, so what if we do surgery? What's the recovery? I'm like, let's, cross that bridge when we get there, if we get there. But it's just to tell you that it's a possibility. And then if it is, I can still help you with that.
Now, you've mentioned to me earlier that you have a few things that you see sometimes and maybe have some different ways, things that you can do with these entities. Tell us about first Seiver's disease, and then right after that, shin splints. They're kind of related. They're both.
Yeah, they're kind of related, like you're saying. So, for whoever doesn't know, so Seiver's disease, basically, it's a calcaneal apophysitis, which is when the Achilles tendon, it inserts on the bone, and then with kids, there's a growth plate. So basically, there's a piece of bone, and then the piece of bone there, but like in between, it's just connected by some cartilage. And then oftentimes in kids, that's why it's related. Like we were saying, is that the kids, they grow really fast, right? They grow fast, they have like growth spurt, and then sometimes the bone grow fast, but then the muscle have a little trouble catching up. So what happens that you get some tightness in the calf muscle, and then it creates a traction onto the back, because the Achilles tendon, it's inserted in the back of the heel, and it's going to be pulling there, and then it's going to be creating some traction on the cartilage, which is not as strong as bone that's on both sides, and then that can cause some inflammation. And then similarly with shin splints, I've seen patients sometimes coming to see me, like young athletes or something like that, and then they were coming to see me. I was working in an orthopedic group in the past, and then they would come and see me. They've been doing like physical therapy, they've been in a boot, they've had MRI, they've like all those things, and then they're like trying to do some, I don't know, different like exercises that have been told them. And then I look at them and I'm like, oh, so with despite all this, I'm like, you still have a very tight calf muscle. And then sometimes they haven't even been told to stretch their calf. And I'm like, the mechanic of the shin splint, it's just that it's the same thing. It's an imbalance because the calf muscle is tight because people, those kids are growing really fast. And then the front muscle, the anterior tibial tendon, everything like that, their goal is to lift up the ankle. And then if the back is so strong and the front is just like having to work so hard, so that's why you're going to get shin splint. You're going to have pain in the front at the muscle because the muscle is becoming just too fatigued. And then, so a simple way is just, I tell patients, I'm like, okay, we're going to stretch your calf muscle, and then we're going to strengthen the front. And then I had a patient, she was in pain for so long, and we just did those two simple exercises. And then just like in a few weeks, like she had no pain anymore. So it's just kind of understand the pathology.
What was the mechanism, your favorite mechanism to strengthen the anterior tib?
So I just use a like those band, like the tear band, put on the floor, and then I loop around the foot, and then just step on the with the other foot, and just go race up and down. And then I tell them, when you feel stronger, I'm like, just pull a little harder, and then you're gonna put more tension on it.
Well, since we're on tendons, let's move on to peroneal tendons. You have, I guess, some story of some recent patients that you can share. And
so
things that you do with that.
Yeah, so I had a patient recently. So it's just, so that's also to say, so not to, like shame any other profession or anything like that, of course, but, let's say if you have an injury and then it's been, you go to the doctor, they take an x-ray, they're saying everything is fine, you didn't break anything, it's going to get better. And if it doesn't get better, well, don't wait too long and then go seek a second opinion. So I have this patient, she, let's say about 6 months ago, she started having pain on the outside of her ankle around her peroneal tendon. So she went to see a podiatrist.
Can you show people on your model where that is for our lay people?
Right here. On the peroneal tendons. And then she was placed into a boot, like a cam walker boot, to walk. So for 6 weeks. And then after that, I forgot if she did physical therapy or not. It was with somebody else. So then she got better, but then she still had some lingering pain. Not, terrible, but there was still something there. And then come to like 6 weeks before she saw me for the first time, she's walking and then she's just like kind of in a pothole. She walks in a pothole and then, she twisted her foot and she felt a pop. And then she went to urgent care because she's concerned. She felt a pop and then she has a lot of pain. And then urgent care takes some x-ray, check. Everything is fine. There's no fractures. And then she just goes with her day. And then she's just like, okay, it's going to take some time to heal. And after 6 weeks, still hurting her. So then she calls the office. She comes in. And then in my case, just hearing her story, seeing her foot, right away, I knew what happened. And then she completely ruptured her peroneal longus tendon. So there's a tendon, there's two peroneal tendons. There's the, I'm sorry, my model, like the tibia is at the wrong spot.
That's all right.
So basically there's two peroneal tendons. There's the longest that goes on the bottom of the cuboid and then attached at the base of the first metatarsal. And then there's the brevis that comes here and then attached to the base of the fifth metatarsal. And then when it curves underneath here, there's some people that in the tendon itself, there's a bone just to kind of decrease the friction so that to protect the tendon. And then that's called the os peroneum. In her case, she broke it. So and then it's within the tendon. So if this is broken, it means that the tendon is completely ruptured. And then just looking at her foot, she had a huge bump on the side there because that bone had retracted up to here. So that I took an x-ray and I looked at the x-ray from urgent care and I could see right away. There's here there's like a little bit of remnant of bone. And then over there, there's like that big piece of bone that's there. Then I took another x-ray just to make sure it didn't retract or anything, which it didn't because there's some structures here that prevent it to retract more at the peroneal tubercle. But I told her right away, I'm like, you tore your peroneal longus tendon, and then we're probably gonna have to do surgery. So then I did an MRI, and then of course, it was ruptured. And then in her case, it's not just that. So yes, she had an acute injury, but then also she had an injury before, right? It was kind of chronic, like acute on chronic, right? So, and then looking at her foot, she has a high arch foot. So basically when she's standing up, instead of having like a foot that's, a little straighter, her foot is, I'm going to exaggerate it, but like her foot is kind of like twisted this way. So if you picture those tendons that are coming this way, they're just always under tension. And then in her case, if I went there and then I just fixed the tendon without fixing the shape of the foot, well, there's a chance that it's going to come back again. So what we did, I went in and then it's called a Dwyer. But so basically it's just cutting the heel bone here, removing a little wedge, kind of like close and then like decrease the arch, like decrease the cavus foot, the high arch foot a little bit. And then also like take this portion, the heel bone, just move it a little bit to the side there so that it balances the force a little bit more, it decreases the strength on those tendons. And then in her case, when I did the surgery, that was 2 weeks ago, her peroneus brevis also had a longitudinal tear as well. So I'm glad we did something because, now it would be just like one tendon over like this force of the foot, and then it could just cause a lot of issues in the future.
Have you ever run into accessory peroneal tendons?
I've seen it, I think, once in residency in my foot and ankle orthopedic rotation with the orthopedist. We were doing a case there also like on the lateral aspect of the foot, and then like you open up and then there's an extra tendon, and then that can take a lot of room, and then that can cause some discomfort also. That also like a low-lying muscle belly like of the peroneals also, like that's something that can happen that we kind of just like remove some portion over there.
I had a case recently that it was, I think, a peroneus quadrante, and there's several, as you said, accessory muscles, and they take up more space in that compartment. And she had gotten a surgical opinion to, quote, repair the tendon and do something that was going to be like a reattachment, because it looked like there was a old avulsion fragment or something. And there was no tear, really. It was just it had already fibrosed in that distal part, but her problem was more in the sulcus closer to the ankle. And she rides, so with riding equestrian, there's kind of an up and out motion that is putting tension on the peroneals. And I'm doing some electromagnetic therapy. I did a bioskin brace called the Trilock, and she is improving. What sort of approach would you do with that kind of a patient, right behind the sulcus there, where that's the majority of her pain? And you haven't seen her, obviously, but she does have kind of one of those feet that is kind of riding the outside ridge.
Kind of like more of like a cavus foot or something. So usually, so my patient already had a rupture. So I know she was surgical. I'm a surgeon. I love to do surgery, but then it's always the last resort. So, it's same thing that you're doing. I would use probably like the same approach that basically, yes, an ankle brace, and then also like maybe some physical therapy, like some laser or something, just kind of like help the inflammation and then the healing. I also love in patients that have a cavus foot or a high arch foot to do an orthotic. So, like I always tell them when they have such a high arch foot, I'm like, you can't use something over the counter, because over the counter are not gonna be, they're not even gonna reach your arch, so it doesn't really do a lot. So usually a custom molded orthotic is gonna be better in their case. And then I typically am gonna do a couple of things to my orthotic. Usually I'm going to do like a first ray cutout to kind of like drop the first metatarsal. So if you do this, so then you're like kind of tilted a little bit more. And I'm going to use a lateral bar, which is just like something that goes underneath the, I haven't looked at. I'm sorry. So like it's going to go like underneath and fill this gap there, just to kind of like, once again, tilt it this way. And I'm going to do a valgus pulsing, which is basically this post here. Some people think sometimes that it's a heel lift, but it's not. It's really just to, because it's flat here, it's really just to like tilt the orthotic a way or another. But usually I'm just gonna do like a valgus pulsing this way to kind of offload the lateral aspect of the ankle or of the foot, and then that works really well usually for things like that.
Now, do you feel you learn more of that biomechanical principle information in Canada or the US, or both?
A little bit of both.
What was the advantage of what you got from Canada in the bio? I always assume that since they don't do surgery, kind of like our Australian counterparts who aren't as surgically orientated, that they excel in biomechanics.
Yes.
Was there anything in particular about that program or that you saw or from going home, if you do, that you think that they execute better up there with respect to?
So I do my orthotics, I feel like a little bit differently, maybe. So the way I cast, first of all, this is all Canada. I still do, I don't know if that's what you do, but like I still do prone position, plaster of Paris, like find my neutral position, and then like make sure that try as much as possible to put the leg in line with the heel, and the heel in line with the forefoot. Just kind of have everything straight. And then if there's any like supinatus, which is when let's say you're putting everything like nice, and then sometimes your first metatarsal, your first ray is just kind of like quick in the air up there. But then if it's reducible, then you can just bring it down. It's called supinatus. And then I'm gonna correct all this, and then I feel like I just get such a better handle of doing all this and like really putting my hand into it to have an appropriate casting mold and send it to the lab. And that's all Canada. So one of the teachers that we had in Canada, I think he's very good mechanically. He's he's been dealing with some like athletes over there, like hockey player and things like that. But then I feel like he had trouble explaining to us what he meant. I feel like it was just like all over the place in his head. Like he knew like so much. He was so excited, that it was like kind of hard. So I feel like when I was in school, like I feel like biomechanics was just like really hard. But then when I started working actually, and then like in Canada, and then like really like, you know, every day touching at feet, looking at this, like seeing like, oh, this foot is very, very flexible compared to all the other feet, or this foot's very stiff, or this foot is like this. So that's really just to practice there. I feel like I got a lot more of a handle. And then after that, when I moved to the United States, and then I did a couple of classes of biomechanics, and then I feel like the way it was presented, it just kind of, I don't
More
know,
organized,
like,
maybe.
yes, more organized, and then just connected the dots even more. So I feel like this whole background make that I'm just very comfortable now with, you know, mechanics, and then doing like, you know, orthotics, and explaining to patient the reason why something is happening.
One thing that I think that as practitioners we do is if we come across something that maybe changes a little bit how we look at the feet, you know, even the contours. Like when I interviewed Dr. Doug Ritchie, he talks a lot about the twisted foot and in utero, how there can be twisted development, etc., and end up with this sort of contoured foot where the mid-tarsus and the ankle are twisted in, and sometimes that will influence riding the outside rail, as I like to say. And the way he presented it changed a little bit how I looked at the contours of the outside of the foot, and then also how I explained it to patients. So even after having all the biomechanics classes, sometimes just sort of emphasizing and looking for things and then seeing them is a good way to highlight that to patients.
Yes. And then I remember, because, you know, when I feel like when I was in school in Canada, we used to always say like, oh, a hyperpronation of the subtalar joint. That was like a lot of like the time the diagnosis, or like and then sometimes I would see somebody, and then I was like, your foot is not really flat, but then they had symptoms, and then I was just like, I couldn't understand. And then I remember when I went to NYCPM, like they introduced the calcaneovarus, and then basically, you know, like you're looking at the foot when they're standing up and everything looks good. But let's say if you're looking at the foot non-weight bearing, and then you're just putting in the neutral position, your calcaneus is a little bit tilted this way. So that means whenever you're standing up, it can be neutral, but you're still gonna do that motion that can go and then like, you know, like put a lot of tension on the plantar fascia, or like pull on the posterior tibial tendon and things like that. So even though it's not a pancake, there's still that degree of pronation that can go in and cause some issues. And then I remember that was like an aha moment for me. I was like, oh my God, this is why. And then I remember I had like seen a patient in the clinic in podiatry school in Canada. And then, you know, I kind of had brushed her to the side, not, you know, like gently, like nicely, but I was just saying like, well, you don't really have a flat foot, you know, like I think you're gonna be fine. And then I had thought about that patient again. I was like, oh no, I'm sure she had a calcaneovarus.
Well, we are in the last minute and a half here, so I want to make sure you get to sign off with your stuff. But first, real quick, we got about 30 seconds. Explain to people, why see a podiatrist? Why not just go and get stuff off Amazon? Why not just go to the Good Feet store? What would be the reason to? I mean, you can spend all day in the Good Feet store and you'll have a technician to help you.
I mean, we are the specialists of the foot and ankle. Like, this is what we do from the beginning. In podiatry school, we learn, you know, you learn the whole body also, like you focus right away from the beginning on the foot and ankle. And then that's just what we do. And then we do like 4 years of that, 3 years of residency. And then things from Amazon and things from other things, you know, you just spend money. I've had a lot of patients come in and coming to see me, and then they like, I've tried this, that. And then what you gave me, it worked right away. I'm like, yes, because that's what I do.
It's kind of like a dartboard. So how do people get in touch with you? How do they find out more in the last bit
Yeah.
here?
So on Instagram, I'm at COMP, foot and ankle care. Same thing. I have a Facebook page as well. And then I have all the information there.
Well, thank you so much for being here, Dr. Blanchette, tonight. And